Bismillah ar-Rahman ar-Rahim. Thanks, Professor Gamal, for this nice introduction. I think no debate about value of complete revascularization in STEMI. The debate is about time and how we can perform this procedure. Coronary perfusion in STEMI improve outcome, but unfortunately 40 to 50% of patients have an additional non-culprit lesion that may worsen the outcome. And as we know, the multivessel disease associated with worsened outcome following primary PCI increase with the number of arteries affected and number of stents. Let us see this case, male patient. Sorry. Male patient, 60 years old, presented by anterior STEMI. He has this tight lesion in LAD and this tight lesion in mid RCA and moderate lesion in distal RCA. Who will vote for immediate revascularization of both LAD and right coronary? Okay. Okay. This is an LAD. Yes, it's presented by anterior STEMI.
Anterior?
Anterior STEMI, tight lesion in LAD, and this tight lesion in right coronary, moderate lesion mostly in distal RCA. You will do immediate revascularization for both arteries or LAD and then staged procedure for right coronary. Yes. Okay.
No, but angiographically, Dr. Mustafa, you cannot swear if this is thrombus or calcium and is acute function, and 20% still may have two culprits, and so unless you are sure that it is calcium.
But the possibility is there. There is a calcification in LAD and calcification in right coronary. So mostly you will do a staged procedure. We have the option culprit only, culprit and non-culprit, and the staged BCI, and which one has advantage and disadvantage in intervention in primary PCI. You will choose according to the old data. 2013, it was harm to do non-culprit BCI, but this changed after multiple landmark trials, including PRAMI, culprit trials, revealed that complete revascularization better than no revascularization or staged revascularization. And FFR trial, the NAMI 3 and compared acute, also the same finding, and the guidelines changed in 2018 from harm to class 2A recommendation until complete trial comparing immediate or complete revascularization versus culprit only revascularization, and the first co-primary outcome, cardiovascular death or new myocardial infarction, better with complete revascularization, and secondary co-primary outcome, cardiovascular death, new MI or ischemia-driven revascularization, better with complete revascularization, better than culprit-only revascularization. And this is a recommendation, changed again to 2021 to class A recommendation. And this recommendation the same for choke patient, culprit only revascularization. Now the question is there, when and how to decide to do complete revascularization. If we look for complete trial OCT subtype, we have 50% of significant culprit stenosis with erosion finding. So stent is the option, and non-culprit obstructive lesion with vulnerable plaque morphology, about 20%. So aggressive medical treatment is needed, and 30% of STEMI patients have only non-culprit obstructive lesions without vulnerable plaque morphology by OCT and need follow-up. The question is there, how and when to identify and to treat suitable lesion? The FIRE trial demonstrates that FFR is very helpful to decide, and patients underwent complete revascularization by FFR better than patients with angiographic finding. And this finding consistent for 3 years FIRE trial follow-up, the same is present. patients treated with FFR better in outcome than patients treated with angiographic finding only. Flower trial, on the opposite hand, no difference in either FFR group or angiography guided group, but FAME AMI trial, the reverse, there is improvement in patients treated complete revascularization by FFR assessment. Timing, multi-star trial demonstrated that patients with immediate revascularization better in cardiovascular outcomes than staged BCI, and same for biovascular trial for acute coronary syndrome. But in meta-analysis, no great difference between both strategy, either immediate BCI or staged BCI. And recently, 2025 option STEMI, no benefit from or non-inferiority was negative in patients treated with immediate revascularization. And this is guidelines now, ACC guidelines 2025 recommendation for complete revascularization in STEMI patients who are hemodynamically stable, class 1 recommendation. Back to our patients, this is a guiding and wire, BTCA for distal tortuous segment, and BTCA for this proximal lesion failed to get a good lumen. This is NEC balloon, and this is cutting balloon. You can see no dilatation at the site of lesion. It's undilatable lesion. And this is after cutting balloon. What we can do. 24 hours later, we prepare a router, and then we ablate this artery. After this, NEC balloon and stenting, and ended with a stent. And this is our result after root ablation and stenting. I think it is a very acceptable result, and right coronary was done at another session. So my home message, we have to individualize our strategy in STEMI patients with multivessel disease, given attention to the following when decide: advanced age, poorly controlled diabetes mellitus, advanced coronary artery disease, late presentation, shock, and high syntax score. And thank you.